So this was a patient with a huge amount of eccentric calcium. So in such situation, one needs to be very careful, and the possibility of annular rupture we should predict. And this patient, you could see there is a very eccentric calcium more towards the right coronary cusp, and we decided to use a balloon expandable valve. Though retrospect, maybe you could have considered even a self-expanding valve in this situation. But then she also had a low right coronary height of 9 millimeters, relatively small annulus with a small LV cavity. The annulus area was 330 square millimeters. Again, to decide on the valve size of this SAPIEN 3 was again crucial. I think, can I have the slides? So we decided whether to use a 20 millimeter valve versus 23, and at that point of time 20 millimeter was not available in India, so it's presently available. SAPIEN 20 is available. At that moment we had a 23, so we decided to implant a 23 valve. So we balloon sized it again. We did a balloon dilatation and did an angiogram at that time, and so we did this is the iodogram, and then once we did a pre-dilatation, during the dilatation we injected, and this is a 20 millimeter balloon. We removed 22 ml, so we underfilled the 23 millimeter SAPIEN 3 valve to be very sure. So we removed 2 ml, and this was a deployment, very slow deployment, and after the deployment, the hemodynamics were good. As soon as the valve was implanted, then after a few minutes we noticed, you could see the rupture, and there was a shunt. Patient was relatively stable for some time. Actually the shunt was from the aorta into the right ventricle, and hence this was the RCC to RV shunt. Patient was stable. This was the echocardiogram where you can see the shunt from aorta to right ventricle. Patient then was, we waited for some time. The patient was quite relatively stable at that time, and we had to keep her in the ICU in the monitoring. The next day, she started developing some symptoms, so we thought we should interfere in this patient. So we decided to take her, and we could see the defect. There was a huge defect, and so we decided to close this shunt. We used an Amplas duct occluder, 1210 occluder, and the shunt, we closed the shunt. But there was some residual shunt that was present. We didn't want there was some paravalvular leak as well, so we didn't want to do anything for that. But patient is now stable and clinically being followed up, though the shunt remains. So this was our only case who had annular rupture, and I would just show two cases. This is courtesy of Dr. Rajmaka. This is a patient with SAPIEN 3 who had 29 millimeter SAPIEN 3 implantation. And following the implantation, there was a large pericardial effusion with hypotension. And so if you look at the CT, again there was an eccentric calcium with the area of 541 millimeter square. So this patient underwent coiling. He did a coiling, and following which the rupture was completely closed with coiling. So this is again one of with 4 coils. So he was able to successfully bail out from this serious complication, and the patient did well. So similar, there's one more case of his, which again was this femoral approach was not a good candidate for femoral approach, high calcium. So they went through the subclavian approach and used a 26 millimeter SAPIEN 3 valve, and the valve deployment went well. But then after the valve was deployed, they noticed huge aortic dissection, type B aortic dissection, and as you could see here, there's a type B aortic dissection. But this, you can see that there's no dissection, the ascending aorta, and the valve functioning was good. So this patient was managed conservatively, and this patient did well with medical management on follow-up. The valve functioning was good, there was no significant paravalvular leak, and there was some mitral regurgitation which persisted. So to show you these examples, though these complications can happen, one needs to pay attention to how to prevent it and also have some tips and tricks to learn how to manage these dreadful complications. So all these 3 patients which we showed were managed, although these patients had a serious complication, they were all managed and were stabilized. So multidisciplinary procedure planning and meticulous CT analysis is very important and must have a bailout strategy and drills for different scenarios such as pericardial tamponade or root injury, and easy access to a heart-lung machine with a surgeon and anesthesiologist is critical in such situations. Thank you.
Thank you, Dr. Sangatrelu. Thank you, Ashish sir and Sharma, Dr. Sharma. Now we go on to the trials to know session. Who is that knocking on my door? That's to basically discuss some of these important trials which are relevant clinically. This session is planned. Request the chairpersons for this session is Dr. P.K. Dev here, Dr. Manish Bansal, Dr. Sanjay Malhotra. Other moderators, Dr. Indra, Dr. Lingaraj, Dr. G. Jana, Shivadatta, Dr. Shiva Banerjee, Dr. Hariom Tyagi. If you are here, please join on the dais. I request Dr. Sharachandra to come on because the other panelists are not there. We have interesting trial session discussed this, and after this we have live cases coming up from KIMS and AIMS where you see some valve cases, and we'll have endovascular session and the dinner symposium. Inaugural function will be after the symposium at 8 p.m. Then we'll have dinner in the same place. Thank you. Over to you, Dr. Sharachandra.
Doctor, why don't you come here? Do you have a good name? No, nothing. Okay, never met you. Okay. Okay.
Your husband was done in Bhubaneswar.
Yeah,
So in our quest to improve not just the deliverability, but also the quality, the acute performance and the long-term performance of intracoronary stents, we have moved a long way, and I'm going to discuss today a trial using the ultra-thin sirolimus-eluting bioresorbable polymer with thin everolimus-eluting durable polymer stents, a trial called BioFlow 5. So, as we know that any new metal drug-eluting stent is going to have thin struts, and this came from the ISAR 4 when we realized that the thinner the stent struts, the computational models depicting flow alterations showed improved flow, the morphometric analysis showed less thrombus adherence. So we have moved from what used to be 150 microns to now 60 micron strut thickness. The second thing in which we moved is how we are going to have the polymer. Is the polymer going to be a biostable polymer, or the polymer is going to be a bioabsorbable polymer? Besides this, we also need to know how well are we going to put the polymer on these struts. Is it going to be a concentric or a conformal distribution of polymer, or is it going to be only an abluminal distribution of polymer, or is it going to be an eccentric distribution of polymer? And this is how we have evolved over a period of time. So this study used Orsido, which is actually the iteration which came from Prokinetic, which is a stent from Biotronic, which used an ultra-thin strut cobalt chromium alloy stent platform with a passive coating of a ProBio, which encapsulates the stent, which reduces the interaction between the metal stent and the surrounding tissue, and an active component called Biolute, which consists of the most proven limus family, and we know sirolimus not just as the first drug, but also is one of the most important drugs. And it is available free to all the, because it's off patent, so it is available easily to all the stent manufacturers, along with a bioabsorbable polymer matrix comprising PLLA, which achieves a controlled drug release. And the actual strut size of this stent for 2.25 to 30 millimeter diameter stents was 60 micron, whereas for more than 3 millimeter diameter stents, it is 80 micron. So this is just, the sirolimus is 1.4 microgram per millimeter square, with 80% being eluted in the first 90 days. And a lot of randomized clinical trials were done which involved the bioabsorbable polymer sirolimus eluting stent, which included the BioFlow 2 study, which was a European study, which was randomized against Xience Prime, and the BioFlow 4 study, which is in Europe and Japan, which is again randomized 2:1 against Xience Prime or Expedition. And then we had a few studies like the Bioscience, which was a Swiss study, and the BioResort, which was a Dutch study. And all these studies had consistent clinical outcomes with low event rates, with target lesion failure at 12 months, which was actually not just in the Biotronic initiated or the, but also in the investigator initiated trials, were reasonably consistently good. In fact, definitely not inferior, and sometimes even considered superior to the existing biodurable polymer stents. So the perspective was that the persistence of adverse events with both first generation and contemporary permanent polymer-based DES presents an opportunity for iterative improvement, including thinner stents, stent design modifications, improved geometry, improved polymer biocompatibility, bioabsorbable polymers. And BioFlow 5 actually compared this. It was a prospective multi-center 2:1 randomized controlled investigational device exemption trial. And this had 1,334 patients which are randomized across 91 centers in US, Canada, Europe, Israel, and Asia Pacific region, where 2:1 randomization of Orsido versus Xience Prime with clinical follow-up at 1 to 6 months, target lesion failure at 12 months, was defined as the composite of cardiovascular death, target vessel-related myocardial infarction, or ischemia-driven TLR, with a 12-month follow-up and an annual clinical follow-up up to 5 years. Standard patients were included, those who had coronary artery disease, stable or unstable angina, with less than 3 de novo target lesions and less than 2 native target vessels, between 2.25 and 4 millimeters in diameter, with lesion length less than 36 millimeters. Kidney flow, usually more than 1, was acceptable, and these were eligible for dual antiplatelet with definite informed consent. Recent STEMI, or hemodynamically unstable, end-STEMI ACS CTO bypass grafts, major side branches more than 2 millimeters were actually excluded. As you can see from the clinical characteristics, they were very well matched, and in terms of age, gender, blood pressure, dyslipidemia, diabetes, prior MI, prior PCI, prior CVG, smoking, and you can see that about 50% of these cases had acute coronary syndromes. Again, if you look at the angiographic or procedural results, about 60% of them had moderate to severe tortuosity, which again looked at the device delivery, as well as being type AHASC B2 or C lesions, which is about 70 to 75%. If we see the procedural outcomes are pretty good in terms of lesion success, which was 99.5% with Orsiro, comparable with Xience. Device success was 97.7%, and procedure success was 94%, which was in fact a little better than Xience. If you look at the primary endpoint of 12-month target lesion failure, the p-value of 0.040, Orsiro performed superior to Xience. And this is important because if we analyze this further, this actually resulted in all three categories of cardiac death, target vessel MI, and clinically driven TLR. This endpoint was a 12-month target lesion failure, which can be seen from this landmark analysis. Even at the 30-day analysis, the bioabsorbable polymer sirolimus-eluting stent of Orsiro fared as well, if not better, than the biostable polymer. Again, we can look at the landmark analysis between 30 days and 12 months, and we see that the difference which appeared at 30 days continues to 12 months. There was, despite a comparable 12-month dual antiplatelet adherence, which is about 92% in both, the stent thrombosis rates were lesser in the Orsiro group as compared to the Xience group. The target lesion failure at 12 months, even by subgroup analysis, we can see whether in terms of small vessels, by age, by gender, by presence of diabetes, lesion length, or the presence of ACS favored Orsiro. Further, what they did was that they took the results of the previous two studies, the data that they had in BioFlow 2 and BioFlow 4, and from these two multi-center regulatory trials, they took out the cases for Bayesian analysis, and they included this, so thus making a total of about 2,200 patients, and they conducted a Bayesian analysis of this. For these patients had to have completed at least 330 days of follow-up, and these were re-adjudicated by BioFlow 5 education committee, including additional events which are not previously adjudicated. And this, if you compare by the Bayesian analysis, again showed that the BioFlow 5 showed that the Orsiro stent, in a pooled Bayesian analysis, performed not just non-inferior, but actually the posterior probability with a post-hoc analysis performed superior to the Xience stent. In a multivariate analysis, this was seen to be also extending whether it was done with more than one vessel being treated, or regardless of the number of target lesions. And this multivariable analysis of target vessel MI also showed that there was a definite significance over the Xience stent. Though the strut thickness in more than 3 millimeter diameter in the Orsiro is 80 microns, but the target lesion failure superiority continued even in these stents which are more than 3 millimeter diameter. So to conclude, it was an internationally randomized trial where the Orsiro was compared to Xience. Differences in MI were observed early but persisted in landmark analysis. There was favorably low TLR in stent thrombosis. There was unequivocal non-inferiority with mean target lesion failure treatment of minus 2.6%, favoring Orsiro, and posterior probability of superiority of about 97%. This was done through statistical Bayesian pooled analysis, taking studies for cases from the BioFlow 2 and 4 study. This was published in Lancet last year. And if we just have a quick review, the importance of fast endothelialization, thinner struts result in faster endothelialization, and it has been confirmed that 65% strut coverage happens at 7 days with Orsiro with reasonably mature neointima and effective endothelialization for better long-term outcomes. So even in the first 48 hours, we can see Orsiro showed better patient outcomes, and this continued up to 1 year. And by OCT data, we know that 65% of struts are covered at 7 days, at 1 month 92%, 3 months 97%, and 6 months 98%. So this is the right quantity and quality of mature endothelialization, and only 4% of uncovered struts were there at 3 months, and there was a reduced risk of late thrombotic events. The Bioscience is another trial which is actually being done, which is going to look at the STEMI subset, and this is also showing an advantage. And we have some future studies in small vessels, and there is a study for reduced DAPT, and there are some investigator-initiated trials like the BioOnyx and BioSTEMI, which may actually be looking at superiority. Thank you very much.
Well, thanks so much for having me. I'm just going to present several trials in the CTO space because it's definitely been quite a year in that space for clinical trials, and I think it helps inform all of our practice, not just in CTOs, but outside of CTO as well. The first trial everybody, I think, is familiar with is Decision CTO, but there's some nuances to the trial that people are less familiar with. This is a trial that was a multi-center trial in Korea that aimed to establish whether CTO PCI compared to CTO PCI plus the PCI of the non-CTO vessels was associated with improvements in outcome. And that issue of multi-vessel disease is really, really paramount for this particular study because I think it helps to explain some of the outcomes. Originally slated to be a much larger trial, it ultimately enrolled approximately 800 patients. And so what was important to note is, this is from the trial design slides themselves, is that patients presenting with multi-vessel disease and the CTO in both arms underwent PCI of the non-CTO vessels as part of the randomization strategy. And then the CTO arm had the CTO done in addition to that. So what that essentially caused is a fair amount of noise between the two arms because both arms were having a PCI of some kind. And that happened in a large number of the patients as a whole. The study flow is shown here. In total, approximately 834 patients were enrolled in a one-to-one randomization to medical therapy versus PCI, but the medical therapy arm also did have the non-CTO PCI as well as the CTO arm. Initially, the trial, there were design slides that were circulated when the trial was initiated suggesting superiority of the CTO arm versus the non-CTO arm. But subsequently, when the trial was presented, it was presented with a non-inferiority endpoint and a curious one with non-inferiority of medical therapy compared to PCI of the CTO. Generally speaking, when one does a non-inferiority trial, you're trying to compare according to an established standard. And in this case, it's not clear that PCI of the CTO vessel is the standard, so this is somewhat curious in terms of its design. To recruit these patients, the study was terminated early, which also in a non-inferiority design would tend to bias towards the null or no difference between treatment groups. Here are the baseline characteristics, and I think the key things that I'd like to point out are that multi-vessel disease was present in 73% of the population, and any PCI was done in 50% of the medical therapy group and 90% of the CTO group, suggesting that both groups were having PCI, which could improve their symptoms as a whole. The total number of stents was shown here in the bottom of the slide, 2 in the medical therapy group, 2.4 in the CTO group, with longer stent length noted for the CTO group, as one might expect because the CTO is being treated. Medical therapy in general was reasonable, although not to the level that was seen in COURAGE. And in addition to this, one can see that the primary endpoint, as was presented at the ACC a couple years ago, showed no difference between the two treatment groups. Certainly, there was no superiority of one therapy versus the other over the follow-up period of the composite death, MI, stroke, or any repeat revascularization. Now, while these trial results were reported as uniformly negative, there are some subtle differences in terms of quality of life scales, and the authors have updated some of these analyses and will be presenting them shortly, if not already at the TCT Asia Pacific meeting, which occurred most recently. Also of note is that there was crossover in both treatment groups. Approximately 20% of patients in the medical therapy group crossed over and had PCI of the CTO, and approximately 15 to 20% in the PCI arm did not undergo successful PCI, further confounding the results. And the authors, to their credit, have published this slide, or presented this slide, in which the as-treated analysis is shown. And it's interesting that while this does not achieve significance across the board, it is pretty clear to see that among the patients who ultimately ended up with PCI, those were the patients with the lowest rate of adverse outcomes, either initially assigned to that strategy or crossing over from medical therapy in this analysis. So the summary of the Decision CTO is that it was presented about a year ago at ACC, and there's no publication yet. We do anticipate seeing these results also with the updated data in terms of quality of life, which the authors have done. Now, a trial that was just published in the past week was EuroCTO, and this is a trial not quite the same size, but originally designed to be the same size, but then did achieve enrollment, and there was also a change in endpoint within this specific trial. This trial was an open-label study of CTO-PCI versus medical therapy, and the primary endpoint of the trial was Seattle Angina Questionnaire outcomes. You'll be hearing a lot about the Seattle Angina Questionnaire because this is a sort of validated instrument to assess angina. The most commonly used metric in this questionnaire is anginal frequency, and that's something we'll talk about in a second. There were also safety endpoints assessed in this trial too. As I stated before, the trial was supposed to be 1,200 patients, but unfortunately due to slow enrollment, only 407 patients were enrolled in the trial, therefore limiting the power to assess complications and or efficacy. Now, one of the things that's unique about this trial, especially in comparison to Decision CTO, is that patients underwent non-CTO PCI up front. These are patients with multivessel disease. They underwent it up front prior to randomization so as to take that noise out of the primary study comparison of CTO PCI versus medical therapy alone. And that's quite important because that prevents the confounding of the results with patients' quality of life improving in the non-CTO arm. It was a 2-to-1 randomization as shown here, and optimal medical therapy was achieved per standard guideline-based measures, but again, randomization and the baseline Seattle Angina Questionnaire assessments were done 4 weeks after non-CTO PCIs were treated. Patients who had CTO PCI could then potentially, if it failed and medical care indicated that they needed something further, such as a bypass surgery, could undergo that. And similarly, patients with medical therapy who failed medical therapy could undergo CTO PCI, but that only occurred in 7%. So much lower crossover seen in this trial compared to Decision CTO. The techniques were generally contemporary. This is a multi-center study done in Europe with retrograde approach done in 36% of patients and a bilateral approach done in 80% of cases across the board. The length of stents was approximately 66 millimeters, and the number of stents used were 2 across the board. Now, in terms of the primary endpoints, this data was initially presented in EuroPCR, and there have been some corrections to the data. Inadequate statistical testing was done, and so the final version that came out last week in the European Heart Journal is reflected here on this slide. And what this basically showed is that there were improvements in both arms in 3 of the 5 domains of the Seattle Angina Questionnaire, most notably anginal frequency, and these were differentially better with PCI compared to non-PCI of these CTOs. So quality of life improvements in a randomized trial of CTO PCI. Additionally, there were no real adverse events that were seen that favored medical therapy over CTO PCI, so this demonstrates that the therapy could be done safely and effectively in this patient population. If one tries to look at the patients that had the most marked improvements in angina questionnaire metrics, such as exercise frequency or quality of life, anginal frequency, and freedom from angina, this was illustrated nicely in this type of analysis, which is also in the paper, figure 2, and in this analysis, there were improvements across the board with CTO PCI compared to medical therapy. Now, those are the 2 randomized trials. I do want to spend a brief second talking about OpenCTO, and the reason I want to mention OpenCTO is because it also centers the side effects and some of these quality of life improvements in a non-randomized fashion, but is important for operators who wish to undertake these vessels. This really sought to look at the best of the best hybrid operators in the United States and Canada, well-versed in CTO PCI. These are the sites that were involved in the trial, including our center in Columbia. Now, CTO success was challenging. You really needed to know the hybrid approach because the initial strategy chosen was only successful 57% of the time. So if you only know antegrade techniques, you're not going to be successful with these cases up to 90% of the time, which is what was seen in the study. Notably, there were improvements in quality of life across the board within the study, reductions in dyspnea in the study, and that was really seen in patients that both got better with open vessels as well as those that had closed vessels. The key point, though, I wanted to mention with CTO PCI in particular, though, are the complication rates. These are not cases that you should just undertake for the sake of undergoing complete revascularization. These cases have a clinical perforation rate that ranges from up to 5% and a periprocedural MI rate of about 2 to 2.5% with mortality that can approach 1% in hospital. So these are stable patients coming in with a CTO with a mortality rate of 1%, some of which is based upon the baseline demographics, but some of which is important because of the complications that can occur. So if one is not well versed in how to treat these complications and how to prevent them, patients are going to have bad outcomes. The specific predictors of complication were age, the retrograde approach, and the height of the JCTO score, and we'll hear more about that here. And all deaths were associated with a perforation. So these are complications that are very, very relevant. I think, the current status of this is it's been published, there's sub-studies published as well, and I think in wrapping up this talk, what I will suggest is two things. One is this past year has had 2 randomized trials. I do think that the trials will generally show improvements in quality of life, but at the downside of this increase in complications compared to conventional PCI. As a result, if we're going to offer these therapies to our patients, it's on us to ensure that they're truly symptomatic, and it's on us to ensure that we genuinely know how to take care of these patients in the most safe and effective way to maximize their outcomes. Thanks so much.
Thank you, Dr. Roshan, for your excellent presentation. Because of the time, we move to next topic. It is Interventional 1 trial by Dr. Roshan. Please.
Good afternoon, esteemed chairpersons, ladies and gentlemen. My trial is Orbita, and I have to explain 2 things with regard to this trial, as the caption says. Why I should congratulate the investigators, but again, in the same breath, I should explain why it should not change my practice. Now, whereas PCI in ACS is a resolved issue, PCI in stable ischemic heart disease continues to be a bone of contention for us. And the reasons are, we are still questioning ourselves what is the best initial management strategy for patients with SIHD, and what is the evidence that early revascularization improves prognosis. Now, you are all aware of these contemporary studies with regard to SIHD, Courage, Barry 2D, FAME 2 stitch, and the last one, that is ischemia, is still going on. Now, what has been, irrefutably proven in these studies is that RCTs have not been able to demonstrate a survival benefit for fixing coronary stenosis in SIHD. And the reasons that have been put forward are that dissociation between the angiographic or physiologic severity of a stenosis and underlying atheroma and propensity to become a culprit lesion. Atherosclerosis is known to be a systemic and a progressive disease with diffuse coronary artery involvement, and intensive guideline-directed medical therapy and lifestyle intervention have changed the underlying biology and natural history of atherothrombotic disease. So the fundamental question that we continue to ask ourselves, if clinical trials in the OMT era show no clear death or MI benefit from an initial strategy of revascularization, do we need to CAT or revascularize patients prior to initiating an empiric trial of OMT? This is the trial I talked about, ischemia trial. It's still ongoing. A large trial, sample size 8,000, average follow-up 4 years. The groups are PCI or CABG plus OMT, whether it is superior to a conservative strategy of OMT alone, with CAT reserved for OMT failure. Composite primary endpoint is CV death or MI, and secondary endpoint is angina-related quality of life. But till the ischemia results are published, we are faced with a situation that is done globally. Size of angina relief beyond placebo is unknown. With unblinded, I emphasize on the word unblinded PCI, the advantage is 96 seconds gain, 55 seconds. In a questionnaire with my previous speaker just alluded to, then they had the blinded procedure. They had the angiogram, and they also had as a research protocol not only FFR but the new IFR, that is instantaneous wave-free ratio assessment also. Then the blinded procedure was carried out, either actual PCI or the placebo procedure. The follow-up assessment again included the same parameters, and both pre and randomization and follow-up included exercise test and stress echo assessment of wall motion abnormalities. The usual blinding procedures were done. Same medical therapy was given to both the arms. The placebo arm also treated as if PCI was done. There was no access to CAT report for patients and their parties, and they were given the same discharge letter. So this is the trial design in nutshell. They started with 230 patients enrolled, ultimately 200 patients randomized, and then divided in the two groups, that is the actual PCI and the placebo procedure. The stenosis severity, FFR and IFR parameters, as you can see here, were absolutely comparable in the two arms. In terms of the primary endpoint result, the change in total exercise time, there was a marginal benefit in the PCI arm compared to the placebo of plus 16.6 seconds, which was not significant. But in terms of the stress echo results, in terms of peak stress wall motion index score, there was a significant reduction in the ischemia burden in the PCI group compared to the placebo group. And you can see the p-value was significant. In terms of the CCS class improvement, the two groups were comparable. So the conclusions of the Orbiter trial was that it is the first placebo-controlled randomization trial of PCI in stable angina. Patients had significant stenosis in terms of the quantitative assessment, FFR and IFR. PCI was safe and physiologically effective. It significantly reduced ischemia burden as assessed by stress echo. And in this single vessel angiographically guided trial, there was no difference in exercise time increment between PCI and placebo. So in context, it was a single vessel PCI for stable angina, guided by angiography. Focus was on symptomatic relief, and intensive medical therapy was given to both the PCI and the placebo-controlled arm. But there are some criticisms. Power of the study to detect a difference between the groups was lower than planned, perhaps as low as 20%. Comparing changes in a parameter such as exercise time is fraught with difficulty when the starting point in the two groups are different. Mean exercise time was 30 seconds higher at baseline than in the PCI group. Population was low risk. Everyone had single vessel disease. The dobutamine stress echo wall motion score was only 1.1 at baseline, and mean exercise time was 8 minutes and 48 seconds at the baseline in both the groups. PCI was able to normalize in the physiology assessed by FFR, IFR. It significantly reduced ischemia burden by stress echo and even increased exercise duration compared to baseline by 28.4 seconds. But remember, the patient's population chosen was little elderly, so within the short-term follow-up of 6 weeks, it is not easy to get an average 65 years old exercise duration up further when it starts at that level of 8 minutes 48 seconds. So just like the OMT used in Courage trial, the real-life scenario is that who does have the time and patience to call patients 3 times per week outside the RCT scenario to assess their response to intensive medical therapy. This is not a real-world proposition. So Orbiter was a trial which was designed to succeed. Beauty of its design is not that it mirrors real-life practice, but it internalizes the clinical uncertainties that cardiologists face. Duration of run-in and follow-up gives an idea of duration in which medical therapy should be encouraged and actively pursued. It also suggests that in patients with an exercise time greater than 8 minutes, medical therapy should be pursued with the greatest vigor. So I thought that I should propose this line of management till ischemia results are published. If you have a patient of stable angina, cardiac CT should be done to exclude LMCA disease or LMCA equivalent, as is also being done in the ischemia trial. Give OMT for a short burst. If symptoms improve and patient is satisfied, continue OMT. If symptoms don't improve, go for exercise stress test. If exercise time is more than 8 minutes, continue OMT. If it is less than 6 minutes, FFR-guided PCI should be done. So my reaction to Orbiter, keep on stenting judiciously in stable ischemic heart disease. So to conclude, ladies and gentlemen, whether PCI is indicated for better outcome in stable patients with CAD, independent of symptoms, could not have or nor was it intended to be addressed in Orbiter. This will require a much larger RCT using state-of-the-art technology such as ongoing ischemia trial. But a rider from this Orbiter trial that 4 patients in the placebo group had pressure wear related problems. Whether it was accidental or operator inexperience is not known to us. But this will lead to more use of non-invasive FFR with CT or MRI at the same time when the first assessment is done is to be a more accessible alternative. Thank you very much for your patient hearing.
Thank you, Dr. Kumar. Now I invite Dr. Chandra to the next topic. How does it change our practice of PCI in a patient affected population on worldwide problems?
Thank you. These two trials, Pioneer AF, which came in 16, and the Redual PCI that came in 17, have shed a certain light on the treatment of patients of atrial fibrillation or those who are receiving oral anticoagulants in the long term for a variety of indications. If they undergo PCI, how do you manage their oral dual antiplatelet therapy? Look at this patient, a classical case of a 65-year-old lady who presented with acute coronary syndrome with ST depression in inferior lateral leads, positive troponin. Creatinine was 1.8, which boils down to a eGFR of about 60 to 70 ml, given her body weight, and cath lab is available, and she's a known case of atrial fibrillation. She has a CHADS-2 vascular score of 4, currently taking dabigatran 150 milligram twice daily for atrial fibrillation, and the last tablet she has taken was 8 hours ago. Now, in this kind of patient, there's likely to be confusion. How do you manage this case? Now, what is the prevalence of this problem? Up to 30% of atrial fibrillation patients who are on vitamin K antagonists have coronary artery disease and are potential candidates to receive DAPT in the near future. Between 5 to 10% of patients undergoing stent implantation necessitate oral anticoagulation in the long term for a variety of reasons. So if that is the case, what is the issue? The issue here is you need to combine in these patients vitamin K antagonists along with dual antiplatelet therapy if they undergo PCI and receive a stent or two. This combination is good because it reduces the risk of thrombotic events, but it markedly increases the bleeding risk up to 3 to 5 fold because of the presence of all 3 agents, which is popularly called triple therapy. One of the first trials to look at the outcomes in this kind of scenario is the VOYAGE trial. It was published way back in 2013. What have they done? They have taken one arm which was given triple therapy in the standard fashion of aspirin plus clopidogrel plus vitamin K antagonist, and in the other arm they just gave oral anticoagulation along with once daily clopidogrel. It was given for 1 month minimum after BMS and 1 year minimum after DES. They looked at this because they hoped that by excluding aspirin, the bleeding complications would come down without an increase in the stent thrombosis. Now, what are the results? The dual therapy and triple therapy more or less are matching in their baseline characters. Atrial fibrillation was the predominant indication in nearly 70% of the patients. A mechanical valve was present in about 10% and other indications in about 20%. Acute coronary syndrome was the indication for PCI in about 25 to 30% in both the arms. Now, the results show that the mortality, myocardial infarction, target vessel revascularization, stroke of any kind, and stent thrombosis, they are all more or less same in both the arms. Particularly important is to note that the stent thrombosis incidence has not increased with dual therapy of vitamin K antagonist plus clopidogrel. It is expected that by excluding aspirin, the chances of stent thrombosis may increase, but it has not happened, indicating that probably vitamin K antagonist given in proper dose along with clopidogrel is enough to prevent stent thrombosis. But what happened to the bleeding complications? You can see here on the top, there was a 44.4% incidence of bleeding complications with triple therapy, and in dual therapy it is just 19.4%, indicating that triple therapy markedly increases the risk of bleeding complications. Now, the new P2Y12 inhibitors naturally have come into the picture because we know that the so-called NOACs, whether it is dabigatran or rivaroxaban, are associated with lesser bleeding complications compared to vitamin K antagonists. These drugs do not require close monitoring. There is no need of repeated testing. And most importantly, the intracranial bleeds are considerably less in the case of NOACs. The first trial in this regard was Pioneer AF PCI trial. Here they have tried 3 arms. One is, of course, the standard vitamin K antagonist plus dual antiplatelet therapy, the so-called triple therapy in one arm. And in the other 2 arms, rivaroxaban was tried in differing doses. One arm had 10 or 15 milligrams of rivaroxaban along with clopidogrel. It is like the OS trials test arm. And the other group is rivaroxaban 2.5 BD plus DAPT for 1 month, followed by 15 or 10 milligrams of rivaroxaban along with aspirin once daily. That is like the Atlas group. What did the results show? The results show that Pioneer AF PCI shows similar rates of thromboembolic events across treatment groups with low power to demonstrate efficacy. The MACE rates were same in all the 3 groups, and stent thrombosis also has not increased in those 2 groups of rivaroxaban where aspirin was excluded. What happened to the bleeding complications? You can see here that compared to vitamin K antagonist plus DAPT, rivaroxaban plus DAPT had significantly less bleeding complications, and even the other arm also had 16.8%. And you can see in the slide that both the arms of rivaroxaban have got significantly lower bleeding complications compared to the triple therapy. And after this, Dr. Deepak Bhatt has written an editorial saying that this is probably the beginning of the end of full-dose triple therapy with warfarin. Immediately or very soon came the redual PCI, which was presented in European Society of Cardiology meeting last year. And this one has tried dabigatran, 150 milligram dose as well as 110 milligram dose, along with clopidogrel. And of course, the third arm was the standard triple therapy. And let us look at the results. And you can see here that there is significantly lower rates of ISTH major bleeding with dabigatran dual therapy. Both 110 and 150 had lower incidence of bleeding complications, slightly higher with 150 milligram dose. And you can see here that TB major and minor bleeding also were significantly lower with dabigatran dual therapy. Intracranial hemorrhage obviously is significantly less with dabigatran in both the arms compared to the warfarin, and the dual therapy with dabigatran was non-inferior to warfarin triple therapy in terms of efficacy. So when you use the NOACs along with just clopidogrel, you have equally efficacious regimen without the incidence of increased bleeding complications. So this particular patient, in view of her slight renal insufficiency, was discharged home on rivaroxaban 15 milligrams a day with Plavix 75 milligrams a day. Only on the first day she received aspirin 325 milligrams. The conclusion from both these trials and the worst trial is that you can get away by using the NOACs with just clopidogrel once a day. Of course, into this group, the prasugrel and ticagrelor do not come, because there is one trial done from Munich where they tried prasugrel along with the NOACs, and they found that the bleeding complications were considerably higher. So if you are going to use oral anticoagulation, the P2Y12 inhibitor of choice is simple old clopidogrel, and probably that's the way to go. Thank you.
Good evening, Chairman, ladies and gentlemen. I would like to dedicate this presentation of mine to Late Chief Latif, who was an adorable chief and a great human being from this great city, Hyderabad. I will be discussing the 4-year trial where PCSK9 inhibitor evolocumab was used and what is its impact on the lipid targets in future. atherosclerotic cardiovascular disease, there is an alarming increase in prevalence and incidence. Prevention holds the key for success in this battle against atherosclerotic cardiovascular disease. Dyslipidemia is one of the major modifiable risk factors, and when treating dyslipidemia, the focus is on LDL target. And while reducing LDL cholesterol, we have already therapeutic lifestyle changes, statins and ezetimibe on board, and now PCSK9 inhibitors are knocking on the door. What is this PCSK9? This is a pro-protein convertase substitution flexin type 9. This degrades the LDL receptors, so the LDL cholesterol goes up. So if you give PCSK9 inhibitors, it will reduce the degradation of LDL receptors, the LDL cholesterol will come down, and in this study, Fourier, evolocumab was used, which is a fully humanized monoclonal antibody. Bioavailability is 72% and half-life is 11 to 17 days. In this Fourier trial, 27,000 patients, high-risk, stable patients with established cardiovascular disease were studied. They did not reach the LDL cholesterol of less than 70 when they were randomized to evolocumab versus placebo. And at the end of 2.2 years, the LDL cholesterol came down from 92 milligram to 30 milligram. So evolocumab over and above statin not only brought down the LDL cholesterol by 59%, it also reduced non-HDL cholesterol by 51%, ApoB 46%, LPA by 27%, triglyceride by 16%, and HDL cholesterol increased by 8%. And this reduction in LDL translated into a significant reduction in the risk of primary endpoints of cardiovascular death, MI, stroke, hospitalization for unstable angina, or coronary revascularization, and this was by absolute 2 percentage points and statistically highly significant. It also reduced the secondary endpoints again by 2% absolute, cardiovascular death, MI, and stroke. The reduction in LDL cholesterol takes some time, but it grows in time. As you see in this, in the first year, there was 16% risk reduction, whereas in the second following year, there was 25% risk reduction in the key secondary endpoints, as well as fatal, non-fatal, MI, and stroke. So lower is better, and this benefit accrues down to the level of 20 milligrams of LDL cholesterol. So with this low LDL we are achieving, are there any concerns about the safety? The study shows there is no concern because there is no difference between the two groups as far as adverse events are concerned, except probably the injection site reaction with evolocumab. And other point which all of us are concerned is the neurocognitive events. There is no difference between the two. And even those subjects where the LDL cholesterol was less than 20 milligram, there is no difference between the two groups. It came to neurocognition, liver enzymes, muscle enzymes, non-cardiovascular death, or hemorrhagic stroke. So evolocumab, when you give on background of statin therapy, lowered LDL cholesterol in this study to a median of 30 milligram per deciliter and reduced the risk of cardiovascular events. These findings show that patients with atherosclerotic cardiovascular disease benefit from lowering of LDL cholesterol levels below current recommended targets. This is also supported by some sub-studies of Fourier. When you looked at the diabetic population, it effectively reduced the LDL cholesterol in this diabetic population and reduced the risk of endpoints. It also looked at the patients with peripheral arterial disease who have a high risk of cardiovascular events. The PCSK9 inhibition with evolocumab significantly reduced that risk with large absolute risk reductions. Moreover, lowering of LDL cholesterol with evolocumab also reduced risk of major adverse events. Then this Ebbinghaus study looked at the so-called neurocognition in a more objective manner by using the Cambridge neuropsychological test, and they found that no clinically relevant or statistically significant changes were observed with the addition of evolocumab to statin therapy. So again, these findings leans strongly towards supporting the safety of lowering LDL cholesterol below the current recommended targets. We also looked at certain subgroups which are going to probably derive additional benefit by using evolocumab, and they found that those patients who had recent myocardial infarction, those patients who had multiple myocardial infarction in the past, and those patients who have multivessel disease will derive more benefit with use of PCSK9 inhibitors. The Gregor study, which looked at 970 patients with IVERS at baseline and after 78 weeks of evolocumab, found that there is significant reduction in total atheroma value in the group of statin evolocumab group as compared to the statin monotherapy. Also, nearly 81% of them patients showed regression as compared to only 48% patients who are on statin monotherapy. So we have come a long way. Initially we thought high cholesterol is bad. Later on we learned that even average LDL cholesterol is not good. Then with TNT and ProVitimi study, we learned that lower is better. And with IMPROVE study, we know that even lower is even better. With this 4-year study, we now know that lowest is the best. But PCSK9 inhibitors are pricey. They are quite expensive. So do we have certain group of patients who are going to benefit much more? So they try to identify what is called the highest risk, highest benefit group. So we should adopt this strategy of highest risk, highest benefit group. The patients who are going to benefit most are patients with atherosclerotic vascular disease plus diabetes, patients with ASCVD plus CKD, patients with recent acute coronary syndromes, patients with uncontrolled risk factors, patients with peripheral arterial diseases, CHD patients more than 65 years, stroke patients, and coronary heart disease patients, and familial hypercholesterolemia. So we have these guidelines, particularly from the Western cardiological societies. The LDL target has been set as less than 70 mg/% for very high reserve. But Lipid Association of India, for the first time in 2016, came with the guideline that LDL cholesterol should be less than 50 mg in very high-risk patients. Then followed the ACE guidelines, ADA guidelines, and Taiwan Cardiological Society guideline, which all say that LDL target should be less than 50. So with these studies in background, probably the future lipid targets in group of patients who are at highest risk and who are going to benefit should be less than 50, and it can come down to up to 25. So in conclusion, Chairman, ladies and gentlemen, PCSK9 inhibitors are knocking on the door. They are welcome to the present armory. Target of LDL cholesterol in high risk, high benefit group, still lower, is still better, and is quite safe. Thank you.
Thank you, Mr. Chairman. My job is to, in a very short period of time, as the last speaker of the day, try and keep the attention of everybody here to try to see what trumps multivessel PCI or CABG in patients with multivessel CAD. So, a quick background. This topic's been obviously debated for many years, with every advancement in PCI starting from POBA to bare metal stents to now second generation, third generation drug-eluting stents. CABG has always trumped PCI in multivessel disease. And this difference continues to be substantial in patients with diabetes, in spite of sort of an improved performance of drug-eluting stents in most other subgroups. And most of these differences have been largely driven by differences in TLR and largely due to the protective effect of the left internal mammary artery. So the objectives of my talk is to review data that's relatively new from 2018, understand what the shortcomings might be of the data, focus on why PCI has fallen short, and then provide a framework for a management algorithm that I think makes sense, and then end with a case example. So a quick clinical vignette to just sort of get the talk going. He's an 80-year-old guy, he's got an ACS, his strokes are positive, he's got the usual risk factors, his creatinine is 1.7, he has mild LV dysfunction. He's had a remote PCI to his diag. He's got peripheral vascular disease, and he's smoked in the past, his STS score is 6, and he has moderate COPD. These are his baseline angiograms. So as you can see, he's got clearly multivessel disease. He's got disease in the left main extending into the LAD. He's got a lesion in the ramus or high OM. He's got a high-grade lesion in his right coronary. Let's focus back and look at some data that was most recently published last month in the Lancet that looked at patient-level meta-analysis from 11 PCI and CABG studies enrolling more than 11,500 patients. In this study, you can see that patients who had PCI and had multivessel disease had a higher mortality up to 5 years. And that mortality difference was statistically significant. It was a hazard ratio of 1.2 with a fairly tight confidence interval. They also looked at stroke. And similarly, patients in the same subgroup who had underwent CABG had a significantly higher incidence of stroke in that same time frame. If you break it down into those patients who had diabetes and to those that didn't, you can see that the difference is a little bit more glaring in patients with diabetes, regardless of whether it being type 1 or type 2, with a difference of 15.7 and 10.7, with an absolute difference of roughly 5%. Whereas those that just had multivessel disease without diabetes, there was really no difference. As you can see, the difference was 8.7 versus 8.4, which was statistically not significant. Interestingly, patients with left main disease in the same meta-analysis, which was also looked at, did not have any difference. So why do we believe that we've fallen short with PCI? Well, I think there are several things. The first thing that comes to mind is, have we really been able to achieve complete revascularization with PCI as compared to CABG? And that's the question we need to ask ourselves. Second is, have we really been able to treat the most common reason why we can't achieve complete revascularization, i.e. a CTO, successfully in a reliable fashion with a low complication rate? Number three, have we employed contemporary PCI technique? Have we used adjunctive imaging? Have we used functional PCI? Or have we just used angiography to determine who gets stented and who doesn't? We do know for a fact, based on data, that everolimus-eluting stents are clearly better than paclitaxel-eluting stents. And that was elegantly demonstrated by Dr. Call with the Tuxedo study in diabetics that was published in the New England Journal, as well as previous data that we clearly demonstrate based on the SPIRIT 1, 2, and 3 data that Dean Kyriakis has presented and has published since. And the last question is, what happens when the surgeon says no? And that's real life, right? I mean, a lot of the times we end up in a situation where we have surgical turndown patients that also need to be treated. That takes me to a study that is going to look at this in a little bit more detail. And that study is called the Optimum Study. That is, has commenced, and we're in the study enrolling patients to try to look and answer this very question. Ajay, who's here, is part of the steering committee of this study. And the national co-PIs are Aaron Grantham, Dave Kanzari, and Adam Salisbury, housed in the Mid-America Heart Institute in St. Louis. So what the study is going to look at is, with a core lab adjudicated manner, the completeness of revascularization, and then follow these patients at 1, 6, and 12 months. And these are patients that have been surgically turned down. They will either be treated with guideline-directed medical therapy or will have index or staged PCI as deemed appropriate. And then we're going to be looking at 1-year MACE and 5-year mortality. What this is going to tell us is describe anticipated risks, benefits, and give us answers about what happens to patients who are deemed high risk and have been turned down from that surgery that now come back into our court in the cath lab. This is a type of form that the surgeon has to fill out when he signs up to participate in this study. It's not part of the patient chart, but he has to provide a primary reason why he thinks this patient is not eligible for surgery, and then enlist all other supporting criteria that he may have that might add to that, namely poor targets, poor age, lung disease, frailty, immobility, prior stroke, infection, pulmonary hypertension, obesity, etc., etc., etc. And then the last thing is, there is a comment at the bottom that looks at what the surgeon's personal assessment of his STS score is, rather than just looking at the STS score as we know it. Let's talk about this business of complete versus incomplete revasc. We'll look at syntax first, and as you can clearly see, if you have incomplete revasc and you have a residual syntax score greater than 8, as shown in the green panel, you have an estimated event rate and a MACE rate of almost 60%. You compare that to a patient who has a low syntax score of almost 0 at the end of his procedure, and his 5-year MACE rate is almost half that. Similarly, all-cause death in the patient that has the highest syntax score is almost 4 times higher than somebody whose syntax score is 0 or 0 to 4. This is a more contemporary study that was published in CIRC that looked at the outcomes, both acute and long-term, in patients with multivessel disease with complete and incomplete revasc, with contemporary drug-eluting stents, all done angiographically. And once again, clearly demonstrating that MACE-free survival up to even 5 years is significantly better in patients who have complete revascularization. And then the real question is the residual syntax score predictive of functionally complete revascularization? And the answer is yes, because if you eliminate the incompleteness of revascularization, you find that the residual syntax score is no longer predictive of long-term outcomes. This is the FUI experience, which is the largest study, that is a single-center Chinese study that looked at almost 12,000 patients, and again divided them into 3 categories. Those that had complete revascularization, those that had relatively incomplete revascularization, and those that had incomplete revascularization. And once again, you can see that the baseline syntax scores at the bottom in the red panel have a clear gradation, 9 being that for patients who had complete revascularization, 12 being those that had relatively incomplete revascularization, and 21 that had incomplete revascularization. Once again, in a more complex, more triple vessel disease with CTOs is where we fare the poorest with PCI, because we are unable to provide them with the same degree of benefit that a surgeon can. This is, again, looking at this with the syntax score in the y-axis and the baseline syntax score on the left, clearly demonstrating that the higher the baseline syntax score, the higher the residual syntax score, hence poorer the outcomes. Again, all kinds of outcomes, death, myocardial infarction, revascularization, are all significantly worse in patients that have a high residual syntax score. So how can we optimize our PCI results? Well, we need to first deal with the technical limitations in dealing with complex disease. There needs to have operator expertise to achieve complete revascularization, and sometimes that means having a retrograde skill set. We got to do better than use adjunctive imaging less than 20% of the time. And plus, we need to be able to act on the information we have from the adjunctive imaging, i.e. have competencies in the use of atherectomy, both orbital and rotational, and use laser. And the last but not the least is we need to do a better job with secondary prevention and guideline therapy post-PCI. This is clear evidence across the board in all the different lesion subsets that we would consider high risk. Long lesions, bifurcations, osteals, left mains, where there's clear evidence that use of intravascular ultrasound provides mortality benefit and reduces MACE, and yet worldwide the use of IVUS is less than 10%. What about management strategies that I would recommend in patients with multivessel disease today? I would suggest that patients with multivessel disease, if they're clinically eligible for either CABG or PCI, should possibly be considered for CABG, especially if they have left main disease in addition to complex multivessel disease. If they have multivessel disease with diabetes, once again, CABG is probably on the table, or at least in the discussion. If you don't have diabetes, then there's clearly an opportunity to assess patient preference, have something we call shared decision-making, look at factors that we would consider favorable factors for PCI, i.e. patients who have potentially a high stroke risk with CABG, patients who potentially would not recover well after a long operation like bypass surgery, and have a high risk for AFib, bleeding, and wound complications with a sternotomy. We're going to look at this more carefully in the FAME-3 study, which is going to look at all comers with 3-vessel coronary disease, excluding left main disease, where a heart team identifies patients that are randomized to PCI or CABG, and then perform FFR-guided PCI with a contemporary drug-eluting stent, or CABG, and then the primary endpoint being 1-year death, stroke, myocardial infarction, and revasc. And it's being powered for non-inferiority, with a key secondary endpoint that will look at 3-year death, MI, and stroke. So going back to our last case, so here's this guy, his syntax score was almost 40, but he was 80 years old. Our surgeons turned him down. So his angiogram, as you remember, was fairly complex. So we optimized his right coronary with orbital atherectomy and intravascular ultrasound and implanted 4mm drug-eluting stents all the way from the crux up to the right coronary and post-dilated them approximately with a 5.0 after intravascular ultrasound demonstrated that to be the size of the vessel. Then attacked the left main and once again was able to perform orbital atherectomy, intravascular ultrasound, drug-eluting stent employment of the left main into the LAD. After a suitable part of the LAD using dedicated catheters like a supercross and twin pass, was able to get into that first and second OM and treat the bifurcation appropriately with a DK crush and end up with a result that looks like this. So in conclusions, I would suggest that CABG PCI for multivessel disease is not a single answer. It's a nuanced topic, and is not a question that can be answered by a single randomized controlled trial or even a single meta-analysis. And the reason for that is threefold. The event rates for hard endpoints are low. Technology is thought of as outpacing the results of the trial, and follow-up for these patients needs to be a lot longer than what's being done so far. However, there'll be more questions that will come from prospective registries, big data, embedded trials, which will help us answer these questions. But I think the answer most often will come from the patient with shared decision-making to allow us to take care of an individual patient in the best way we can. Thank you.
Thank you, Dr. We have to move to the next session now because the live case is ready. Let us have a big round of applause for all the speakers for the very the topic comprehensively and sticking to the time. Thank you.
That's okay. Okay, it's time for the live cases again, and for this, let me invite Dr. M.S. Sirimath, Dr. Uday Kanolkar, Dr. H.M. Adikar, Dr. Yashpal Sharma as chairpersons onto the stage, and as moderators, Dr. Muhammad Shalub, Sai Sudhakar, Saki Kurutukulam, Shuva Datta, Rajiv Menon, Ravi Cherian Matthew. We are slightly late by 5 minutes, Sirimath.